So we're going to do alterations in respiratory function. So obviously, I always like to talk about normal before we talk about abnormal. I think it's really important. If you understand normal, you can figure out abnormal. We are talking about, when we talk about oxygenation, in relation to the respiratory system, we are basically talking about CO2 and O2 exchange, okay? So if we were to look at trying to add a slide. Hold on one second. If we were to look at the alveoli, which is basically the end point, correct? So you have the trachea, left and right, bronchus, and then they go down into the little bronchioles, and then the alveoli, okay? I'm obviously not drawing to scale. The whole point of the respiratory system is along each one of those alveoli, you have capillaries that follow it, okay? And you have deoxygenated blood that comes to get oxygenated, all right? So as you're taking breaths, you are blowing off CO2 and getting O2 to pass out to the body. It's the whole point of the respiratory system. So when we have alterations to respiratory function, what's happening is that there's some reason why we aren't having this exchange. So as we talk about it all the time, we're going to talk about why aren't we having this exchange, and then how do we fix it? Because if we're not having this exchange because of a blockage, it doesn't matter how much O2 I throw at them. If there's still a blockage, increasing the O2 is not going to change anything. And that's where NCLEX wants to make sure you understand what's causing the problem, because they're going to ask you something like, if whatever the disease process is, the blockage, what is your next step of action? And it's going to be 1, like suction, 2, O2. And a lot of you will want to choose like give more oxygen because you're like, oh, their O2 sats are low or whatever reason. But if it's low because of a blockage or some kind of whatever's stopping that process, giving more oxygen isn't going to help. And so NCLEX wants you to be aware of that and understand that as novice nurses, that the obvious, like I know we're talking about ABCs, but that's not always the case. So you have to really understand what's happening with those disease processes so we can treat them the right way. Good? So when we talk about ventilation, that's when air moves in. That's when we have inspiration. So we breathe in, everything kind of opens up, we get air in. That's when we bring oxygen in. And then expiration, we exhale, everything kind of, squishes down, squeezes down. We blow that CO2 off. So we're going to talk about respiratory system in general. And with the respiratory system, getting a really good health history is important. We want to know about their family and their genetics. There are certain things that are more common and along a family line. So something like cystic fibrosis. You cannot get cystic fibrosis unless both your parents have that gene. Asthma is more common along family members. So it's really going to help guide you when they come in with very vague and non-specific symptoms. Knowing their family history can help guide you in that differential process. Immunizations, have they been immunized? I'm not going to get on my soapbox, but I am. So they should all be immunized. We have diseases that are 100% preventable. We're going to talk about epiglottitis, which is something that kids can die from. That is 100% vaccine preventable. So knowing whether they've been immunized or not is extremely important, because if they come in with a presentation of epiglottitis and we're trying to figure out what to do, we can ask, has your child been immunized? If they have, the likelihood of it being that is very low, and we can then direct our differential a different way. But if they have not been diagnosed or not been immunized, then we know what safeguards to put in place. Also, what is their past medical history? Do they have any history of asthma or allergies or anything that's going to put them at higher risk? It's just like a comorbidity. You know, I could be affected by a cold very differently than someone who has asthma. You know, they may not have the reserves that I have, being I have no history. Risk factors, obviously prematurity. Their lungs just didn't develop the same way. Smoking is a huge risk factor. And it's going to be the etiology behind many of our adult diseases. And it's really hard because try to tell a parent, don't smoke. You're not going to get a good response rate or a good compliance with that. And so a lot of times you are just going to have to work with what you've got. And when we're educating them that you know your child's in the ER every month because you smoke. And they're like, well, I'm not stopped smoking. Okay, well, can you smoke outside? Can you at least then get a leather couch so that the smoke doesn't sit inside the cloth couch? Can you change your shirt after you smoked? Because they'll be like, well, I never smoke around them. No, but when you smoke, it's anyone who has ever been around someone who smoked, they smell like it. And then they hold their little toddler up against their chest, up against that, and many of the kids are sick because of it. So it's not an easy topic to talk about families with, and just telling them you can't smoke is not going to get you very far. So really giving them alternatives on how to work around it is going to be important. If they've had any recent infections, like a URI, and are they on any medications, such as, you know, any history of, like adults, if they're on narcotics, does it make their respiratory system lower so they're more susceptible to infection, things like that. Physical exam, the two most important, I know this is going to be shocking, in the respiratory system, one of the most important things you're looking for is the respiratory rate. I just mic dropped it, didn't I? All right, you're all awake. So, big two things we're looking for is your respiratory rate and your temperature. Temperature basically because many of the things we talk about in the respiratory system are infectious, and we want to see if there's any infectious process happening. Inspection is going to be huge as part of your physical exam. What does the child look like? Is the chest symmetrical? Do we notice any cyanosis? Do we note any clubbing? Do they have a cough? Are they retracting? Do they appear dehydrated because they're so tachypnic, they're blowing off? Remember we talked about fluid and electrolytes and they can blow off a lot? What is their mental state? All right, that is going to be one of your biggest first indicators, right? You could have a person that is compensating, you know, their respiratory rate's a little increased, but maybe their respiratory rate is 20 and you're like, well, that's within normal, or 22. And you don't really think it's a big deal, but they seem a little confused. They're a little more agitated, you know. Those are big signs and symptoms that they're not getting enough oxygen to the brain and that we may need to start implementation sooner, okay? So you don't always have this patient that's in severe respiratory distress and then they show signs of mental changes. It's typically first you see like small mental changes and then you see them really decompensate, okay? Palpation and percussion aren't as big. Obviously, they're part of our assessment process, so we mentioned them. You can palpate the ribs to see if there's any fractures or any masses. You can percuss to see if you can any fluid. But the other big one is really going to be the auscultation, obviously. And we really want to know what we're hearing and where we're hearing it. Those adventitious breath sounds, right? So are we here? Adventitious means like not normal, right? The abnormal sounds. So we should hear clear breath sounds throughout. But are we hearing a whistling? Are we hearing a wheeze? Are we hearing stridor? Are we hearing crackles? And where are we hearing them? Upper lobes, lower lobes, because those are indicators of the different disease processes. We also, and it's harder to get a good, if inspection's easy, right? we can look at somebody and walk into a room and get a really good assessment via inspection. Auscultation is going to be much harder on a child. An adult, you walk in and you're like, Mr. Smith, breathe, 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 right? So, but with a child, you're gonna say breathe, and they're gonna be like, yeah, or they're just gonna scream bloody murder with you. So you have to be very creative with them. We will do lots of things, and I have never told a child, take a deep breath in. We give them things like pinwheels. So you'll see pinwheels all over the hospital because, they like to blow on them. We give bubbles, which can be a little bit of a hot mess, like when they're like, and like spitty bubbles are floating everywhere, but whatever. So we do bubbles. You can do creative things. I always tell them, if you give a kid, especially like a preschooler or younger school age child, make it a competition, they will want to take you down in a heartbeat. So if you tell them, oftentimes I'll be like, I bet you can't blow out this birthday candle, and they'll be like, watch me, and then they they're like, I'm like, can you blow out too? And they're like, yep, and they'll take a really big deep breath, and you get the exact same results. You get them to take that deep breath that you want. You be able to get a really good, listen to them, but you have to be a little more creative. And like we talked about before, in the parent's lap, on the floor, wherever you can get them. But inspection and auscultation. Diagnostics, we have all these different things that we can use to help diagnose, and we'll talk about them as we get to the disease process, but basically CBC, we're looking for white count, see if there's any kind of infection. ABG shows us our pH level and our CO2. So remember, the respiratory system, or the oxygenation, referring to respiratory, is all about the exchange of O2 and CO2. So an ABG is a really good indicator of how we're doing in that CO2 exchange. Sputum cultures we'll get to help us identify infectious processes. But we always need to make sure that we get a sputum before we initiate any treatment. So you guys have been out in the hospitals, and you'll see you often get a ton of orders at one time, right? Like, do these 7 things or do whatever. Especially if you're working in the ER or clinic, if they come in and the doc orders, they're concerned about an infectious process, and the doc orders a CBC and an ABG and start these antibiotics, and you don't see a sputum culture on there, again, this is a good test question. Like, little Tommy comes in, rule out pneumonia. He's 4 years old. The doc orders, blah, this, and an ABG, a CBC, antibiotics. These are the vital signs. What's the nurse's next action? A, start the IV. B, call the doctor and question the order. C, those type of things, right? This sounds like a typical nursing question, right? What they want you to know is that the doctor forgot the sputum culture, and that you're not going to start those antibiotics that the doc asked for until you get that sputum culture. Because once you start antibiotics, now I can't get that culture, because even if I do, the results are going to come back, abnormal. So they want, and you all know that. You can tell me, when I'm having conversation with you, you can sit there and tell me, I know to get a culture before I start antibiotics. But what they're trying to do is see how you apply that information, okay? TB, we'll talk about that specifically when we talk about tuberculosis. A pulse ox obviously just measures the amount of bound hemoglobin in the blood, and then chest x-ray, CT, helps us, on a chest x-ray, basically, or any kind of x-ray, black is air, anything white is a solid mass or organ or fluid. So with the chest x-ray, obviously the only white we want to see is the bones. So we just want to see the ribs, the clavicle, the outside of the chest. We should see pretty much black, in between everything else. So a chest x-ray shows us if there's any fluid or a mass in there. A CT, if we do see something on a chest x-ray that we're concerned about, or, we want to follow up further, then we can get a CAT scan of the chest, and that would give us a more detailed vision of what's going on. There's different oxygen delivery systems. So at the bottom there, you've got the non-rebreather mask. The little baby in the oxy hood. Look how cute that baby is. An oxygen tent on that lower right-hand corner. And again, basically you have to understand that there are many different devices out there and when you're going to use them. All right? You are not gonna, they want you to know that I can put a nasal cannula on someone if they're, satting 90%, they're maybe a little tachypnic, they just need a little extra support. But I'm not gonna put a nasal cannula on someone that's got a respiratory rate of, 40 and is really desatting and crashing at the time. They may need a little bit more support, like a non-rebreather. Again, the focus is I understand what these things are and when I'm going to use them. So there's different, look at that fat, happy, yummy baby. I love squishy babies. So differences in pediatrics, I'm going to put them all up here. We've already talked about all of these, right? They have poor tolerance for nasal congestion, especially your infants. Infants are obligate nose breathers until they're about 4 months of age, meaning that when we get a stuffy nose and our nose is clogged up, what do? Breathe out of our mouth, right? We don't even think about it. Babies don't think about it. Like, they can't really do that. So if they get a stuffy nose, they really struggle breathing because they don't think to breathe out of their mouth. They have shorter eustachian tubes, smaller airway diameters, distance between the organs are shorter. So it just basically means that they're at higher risk for developing infections because it's easy for that virus or that bacteria to get to where it wants to go to cause the infection. So remember, their little eustachian tubes are almost completely horizontal until they're about 2 years of age. And then when they turn 2, they start becoming more at a diagonal. And so up until then, if they get a little bit of cold and they get fluid, that fluid just sits there and causes an infection. Whereas us as adults, it can drain down the back of our throat. Their distance between the organs is shorter, so again, the less travel time. They're belly breathers, right? So we need to make sure that when we are doing a respiratory rate that we're really looking at their belly, not their chest. And they have a total body response. So if we get a cold, and it's already started, cold season, we tend to if we have a chest cold, it tends to be just in our chest, right? You guys will walk in here with your box of tissues and everything, and you're like, oh, I had this cough and I feel congested. Or it's just a head cold, it's just here. It tends to be very localized to the respiratory system, unless it's something like the flu. But it tends to be very localized. Kids, even if it's just a little bit of a cold, they will have a total body response. So they will get things like nausea and vomiting and diarrhea and belly aches, and they'll have fatigue and they won't eat. So they will have this total body response even for just a small cold. So we just have to be more vigilant about making sure that they stay well hydrated. If I was you, I would not write all this, but you can if you feel so obligated. The clinical manifestations, I mean. They're very non-specific, all right? For all the things that we talk about with respiratory, you're going to have nasal blockage and cough and sneezing and shortness of breath. Like, we see that with all of them. So your job is to kind of, with each disease that we talk about, what makes this one special? Don't sit there and try to memorize, because you guys will all just spit out. It's like when I say, what labs do you get? CBC, BMP. Okay, well, why are you getting those labs? I don't know. You asked me what labs to get. I'm telling you. So everybody, like if I say there's a respiratory, you'll be like, cough, cold, sneezing, fever. And I'm like, okay, yeah, that's great. What makes this disease process special? So when you're looking at diseases, all of them are going to kind of have these clinical manifestations, right? What makes that one stand out that helps you diagnose it? Because if you know that one thing that's going to make it stick out to help diagnose it, it guides your treatment. And then nursing care management. The biggest thing is that obviously our assessment skill needs to be really on point, including knowing our health history and our inspection and auscultation in our physical exam. That we really need to promote rest, comfort, hydration. All right. And how are we going to know that they're well hydrated? Urine output, right? We see how well they're peeing. Now, are you going to ask a parent how many times a day does your kid pee? No, because they're going to be like, I don't know. If they're still in diapers, you don't ask them how often are they peeing. You say how many wet diapers have they had. And when you give them a goal, you don't say they should have 30 cc's per hour. The parent's going to stare at you and not be compliant at all. You say, I want them to have 2 or 3 wet diapers per day. If they're not having 2 wet diapers per day, I need to see them back immediately because that means they're not well hydrated. So you need to speak in terms of what that, what's going on with that child. Most parents, by the time the kid is 4, stops going. Who's got kids in here? I mean, how many of you after 4 went to the bathroom with your child? Never. Like, would you know any of the bathrooms? Right? Yeah, I mean, you just don't go anymore. So when they say, don't judge a parent when they're like, I don't know when the last time they peed. Like, do you know the last time your spouse peed or your partner peed? Or, that doesn't get talked about a lot. So you may have to talk with them a little bit more, encourage them. We want to decrease that spread of infection, so really good hand washing. A lot of respiratory stuff is spread by, spoiler alert, droplet precautions, okay? Or droplets. So we put them on droplet precautions. We make sure they're washing their hands really well. We want to give good family support, especially with educating about over-the-counter medications, all right? That they need to be really aware of a lot of the over-counter medications that they use for things like colds include Tylenol. And then if they give their child that medicine with Tylenol and then give them Tylenol on top of that, they have the potential to overdose. So really making sure you know everything that they're taking, including over-the-counters, and educating them on any interactions that might occur. Mm-hmm.
Big thing.
All right, so that's the respiratory in general. So now we're going to get to the actual disease processes. Woo! Nobody? All right. I'm on my own here. All right. So we're going to talk about croup syndromes, which are upper airway syndromes. So croup syndromes are defined by where the swelling is located. And the swelling is located up here, okay? Remember, we talked about that essentially the whole point of the respiratory system is to exchange O2 for CO2. And with croup type syndromes, there is swelling that is decreasing that. Okay? So the first one we're going to talk about is epiglottitis. It is a croup syndrome. It's caused by H. flu. And since you just took test 2 and you remember everything clear as day from test 2, you know that H. flu is one of our vaccines that we give to kids. So this disease is 100% preventable if we vaccinate the child, okay? It typically occurs in children 2 to 5 years of age. Clinical manifestations. It is an acute onset. This is a pretty healthy kid that all of a sudden, they were previously healthy, and then all of a sudden they wake up, after nap and they look sick, They have a high fever. They're drooling, muffled voice, tripoding, and anxious. So again, you put the kid down for a nap, they wake up, or all of a sudden the parents start hearing a sound, and they go in to see the kid, and the kid will literally be, I can't do it in a dress, but they will be sitting with their legs out. They'll have their hands in between their legs because they're trying to increase that diameter of their chest. And so they'll sit tripod like this, and they're just drooling, okay? And if they try to talk, it's either very muffled or hoarse. That's because the glottis, which sits right here, is swollen, okay? And if you were to look at the glottis, but none of you are, right? Say no. Good job. You would see a bright red cherry glottis. But we don't, right there. That's what you're going to see. But we don't inspect the throat if we suspect this. So you can have a kid come in. My kid, I'm going to talk about in a second with croup. He's a croupy kid. And he one day woke up and he was suddenly just kind of sick. And he was tripoding a little bit. He was drooling a little bit. But he was well immunized and, the suspicion was very low. Had I said my child's not immunized, we would not have looked at that throat, all right? Because what can happen is if you, use a tongue depressor or have them open, you can have that throat spasm and completely obstruct. And then you are putting in an emergency tracheotomy, okay? So it is very serious. It has a very high risk rate, and you have to be very careful. So we diagnose it by the thumb sign. So if you can see it. Yeah, it is. Oh. Right here. You see this right here? You see how it looks like a thumb pressed into it? I'll go back so you can see. Look at the x-ray without it. You see right here. Yeah. Do you see right here how it looks like a thumb is pressing into the throat? That's the thumb sign, okay? That's the glottis that is swollen and pressing into the throat. And if you put a tongue depressor in there, that glottis will spasm and then just completely obstruct. So now the child just lost their airway. That is again, NCLEX wants to know what's going to make this patient die and how are you going to make your patient not die. We want to make sure we protect this airway. So if we suspect an epiglottitis based on their clinical manifestations and the fact that they haven't been immunized, we would get an x-ray to confirm, but we would basically be preparing to intubate and starting IV antibiotics, okay? It's a very serious condition. We don't want to agitate this child at all. And typically they're on antibiotics for a good 7 to 10 days. And they're getting other things too. They're getting steroids, they're getting racemic epi, they're getting other things as well, but they really need those IV antibiotics to help with the infection of the glottis. Okay? All right. We don't see it a lot, thankfully, because for the most part, kids are well immunized. But if we at all suspect it, it's a red flag, okay? Again, a question would be something like, 2-year-old Tommy comes to the ER with his mom, is drooling slightly, here are the vital signs, is sitting with his hands between his legs, because are they going to spell it out to you and say he's tripoding? No. So they'll say something like he's sitting with his hands between his legs, we notice a little drool on his chin, history includes, that mom doesn't believe in immunizations or whatever. And then it's going to say, because, I'm always telling you guys, use some of those test-taking skills. Like, where are you in the nursing assessment process? So right now, you have a history, so your next thing to do would be an assessment, right? So you're like, okay, let me do the assessment. So 1, look in the throat. 2, do this. And a lot of you will want to do an assessment at this point. What NCLEX wants to know is that you know that this is serious and that the most important thing is to protect the airway, okay? So that's what we're looking for, that you know those kind of red flags. All right. The other thing that we're going to talk about, or one of the things, is LTB, which is laryngeal tracheal bronchitis. So most people, when they say croup, they're referring to LTB. How many of you have heard someone say, my child had laryngeal tracheal bronchitis? No. How many of you have heard my child has croup? Everybody, right? So croup, when they say Croup is extending. We're talking about all these different things. Technically, epiglottitis is a croup, and LTB is a croup, and we're going to talk about it. Tracheitis is a croup. They're all croups. But what you'll hear parents say a lot is croup. They're referring to this, the LTB. All right. It's caused by, RSV, flu, pneumonia, different things. And basically, it's a more gradual onset. They're usually preceded by some kind of cold. So the child has had a runny nose for 3 days. And again, that's the kind of scenario you're going to see. Child presents with runny nose times 3 days, slight cough yesterday. Now, mom is complaining of a whistling sound, which is the stridor. All right. And it's important that we understand that the stridor is when they breathe in. Okay. So when we are listening for this, it is a, okay? Because remember, the obstruction is up here. So they're trying to, when they open up, because right, when we inspiration, we breathe in, we open everything up, they're trying to get that air past the obstruction. They're trying to get it in. And that's why we hear that kind of whistling sound, that stridor. And they have a very barky cough. It sounds like a seal. I won't do it because, I should do it. Then maybe it'll wake you all up. But it's a very distinctive, barky cough. Once you hear it, you'll know exactly what I'm talking about. But it just sounds like a seal is barking at you. They can have a fever. They cannot. Remember, it's just they had a little cold that developed some inflammation, okay, in the laryngeal tracheal area. So because of that inflammation, because of the cold, that's what's causing the stridor and the barky cough. Typically, again, caused by a virus. We diagnose it by this steeple sign. So do you see right here? You see how it goes up and down? You guys see that? So remember, black is air, and anything kind of white or darkish is tissue. So all this tissue along the laryngeal tracheal area is swollen, okay? And it creates that steeple sign. We treat it symptomatically. To be quite honest, these kids are gonna do pretty good, just fine. When we talk about croup, it can exist along a continuum. So it can be a very mild croup, and it can be a very severe croup, and you can have everything in between. So again, remember there's just some inflammation and swelling because of the respiratory, because of the virus that they were exposed to. So sometimes we'll give dexamethasone, which is a steroid, and it's a one-time dose steroid. They typically get it if they seek medical help. So if the parent brings them into an urgent care center or brings them into the ER, then they'll get that dexamethasone. But to be honest, the studies show that it doesn't really make that much of a difference. It doesn't really hurt the child. It doesn't really help. It's inconclusive. But most ERs will go ahead and give it to the child because it honestly makes the parents feel better that they're getting some kind of treatment. If it's really bad, we can do some racemic epinephrine, which is a bronchodilator. We'll do humidification. We can do hydration. But the big thing for them is to just decrease their anxiety level. We talk about supply and demand. We're going to talk about it with the heart as well. But basically, the child has a supply. We all have a supply, okay? And when we are healthy and demands get placed on our system, we can meet it, right? So I'm a healthy individual and my lungs are feeling great and I walk up those dang stairs that kill me. Oh my God, does anyone else get totally out of breath? Okay, so I walk up the stairs, but my supply is good and I can meet that slight demand, even though I feel like I'm gonna die at the top. I can meet that. But now I'm sick, my supply is down here, and if my demand increases, I can't get there to meet that demand, okay? So whenever they're sick, our goal is to try to keep the, demand really low because their supply is already low. So anything that we can do to keep them from being anxious, like we don't want a pissed off child. We're not going to go in there and be doing a lot of things and messing with them a whole lot or taking them from mom, because we don't want them to get more agitated, because that means they're going to decompensate faster. That's the biggest thing we can do for them. The other things, yeah, they help, but honestly, as the virus runs its course, this is going to run its course. It sounds a whole lot scarier than it is. So keeping the kid anxious and then keeping them hydrated. Most of the time, if kids are getting admitted because of croup, it's because they can't keep hydrated. We can, when they're sick, they can do sometimes one of two things. They can either breathe or they can eat. I don't know, I'm going to choose eating, but that's just me. But most people are going to choose breathing first, right? If I can only do one thing, I choose breathing. And so they just won't eat, not because they're not hungry or not because they don't want to, but because it takes so much demand on them to eat that they just choose not to, right? Because they know inherently that I've got to decrease my demand. So most of the kids that get admitted for croup, it's because they just can't stay well hydrated enough. All right. Acute tracheitis is basically when this LTB doesn't respond to therapy and the kid gets really sick. So it just progresses. So acute tracheitis is just a progression of LTB, and they just don't respond to therapy. They end up super sick, they can't compensate, and they end up intubated. And again, a lot of times it's caused by a virus, so we just treat them symptomatically with respiratory support, IV therapies, those type of things until the virus, kind of makes its way out of the system and the kid starts to get better. So it doesn't respond to LTB therapy. They have really thick secretions, cough, fever, and they oftentimes require intubation. Very rarely do we have somebody that goes from croup to acute tracheitis. The other one is acute spasmodic laryngitis. Again, it's a form of croup, kind of extending out from LTB. It's caused by a virus, and it happens suddenly at night. So my son has had this a couple of times. I put him to bed at 7, and at midnight he's waking up because all I hear is, and it sounds a whole lot scary. Honestly, the best thing you can do for this is a cool, cold mist, which is what's right here that you can't see. That cool, cold mist. My husband would always laugh at me because as soon as we would wake up and hear it, I'd like half asleep go and pick him up out of the bed, and then we would just go stick his head in the freezer. Not like his whole body, but like we would open the freezer and we would just be sitting in front of the freezer at like midnight because him breathing in that cool, cold mist. All right. I have had to go to the hospital with him. We did go Christmas Day Eve. So the 25th, that night, he woke up around midnight, had one of his episodes. It wasn't getting better, and because every parent at home has a pulse ox and everything. So we went in. Because his O2 sats were sitting a little low, and he got a dexamethasone. He got like 3 doses of racemic epi, which made him totally jittery. And we sat there in our matching Christmas pajamas all night. Getting treated, but it's just something that happens sudden at night. And again, the dexamethasone helps with the inflammation a little bit. Racemic epi helps with the bronchodilators. What are you having trouble seeing? The cool, cold mist. Cool, cold mist, that one? Yeah. Yeah. So, and those are your croups, okay? We got it? So it's inflammation up here in this laryngeal tracheal area. And the 2 big ones are the epiglottitis and the LTB. So while croup was up in the upper airway, you see right here, we had epiglottitis right up there where the epiglottis was. You have croup or LTB right up here, so all upper airway. When we're talking about RSV, we're talking about the lower airway, okay, more in the bronchioles. So bronchiolitis, etiology is RSV. RSV is respiratory syncytial virus. RSV is what everybody knows it as. And it's more common in the winter and the springtime. And basically what happens is the epithelial cells that line the respiratory tract, they get swollen and they shed. And then the mucosa gets swollen. So you have a swollen mucosa, you have all these epithelial cells that are getting swollen and shedding, and then you have mucus and exudate, and that's what causes the obstruction. These kids are big, hot, snotty messes, okay? There's copious amounts of secretions with bronchiolitis, okay? So croup, it's not the secretions that's causing the obstruction. The obstruction is caused by the swelling. With bronchiolitis, you have the obstruction as well, but the obstruction is caused because of the mucus, okay? So again, can you see where they want you to understand, and when I say they, the magical NCLEX people, they want you to understand that if it is a croup-type syndrome, that suctioning a kid or thinning secretions is not going to help them, but that decreasing inflammation will. But if it's a bronchiolitis, the focus wouldn't be on giving dexamethasone or racemic epi. The focus is going to be on decreasing secretions, right? Okay. All right, we diagnose it by the ELISA for RSV. It is a test that we can do outpatient very quickly. Urgent care centers, ERs, they can test for it. And clinical manifestations, again, it's pretty much very vague, right? They have a cold, they have a high respiratory rate, their breath sounds are a little bit lower. And again, remember, they have that full body response, so they don't tend to feed well. But the big thing for bronchiolitis is that they're just, like I said, big snotty messes, copious nasal secretions. They don't have stridor, because they're not trying to get air in past an obstruction, right? They just can't get air in because they're snotty. And they might have a little dyspnea and retractions because they're really trying to open those airways because they're trying to fill them. So again, if I've got my little alveoli here where I'm exchanging O2, CO2, right? If I now fill this, we'll make snot blue. If I now fill this with snot, okay, can gas be transmitted through fluid? No. It's like me. I can sit there and if I was in a pool and if I was sitting on the top of a pool and I blew a straw and I blew blew air into the straw, into the pool with bubbles, right? I could blow that air in, but is that air going to go anywhere? No. If I was underneath the pool and somebody was trying to blow me those bubbles, would I be able to get them? Not at all. Because that air that's being blown through the water, it can't get to where it needs to go, okay? So again, here's a situation where I'm giving more oxygen, but unless I get rid of the secretions that are blocking where I pass O2 and CO2, I'm not going to do any good. So treatment-wise, our focus is preventing respiratory failure. Again, bronchiolitis exists along a continuum, just like croup does. So you can have kids who have very mild bronchiolitis or RSV, or you can have kids that are really sick from it, and anywhere in between. Our biggest thing is that we want to prevent respiratory failure because they're really working hard to clear this fluid right here. So they're trying to get rid of all this gunk right here, and they're trying to really open up their alveoli, and they're really trying to open up their airways because the gas exchange happens all along this area, right? All along here. So the bigger they make the airway, the more surface area there is to have gas exchange. And so they're going to work really hard they're going to, because they're really trying to open those alveoli and open up the amount of surface area there is to have the gas exchange, to get oxygen in. But how long can we do that? I'm about to I got a little dizzy just doing those 4 breaths. So how they can't do that for very long, right? There's only so long that they can work that hard, and they're eventually just gonna poop out, okay, and decompensate. So our focus is to try to make them more comfortable so that they don't get into respiratory failure. So we want to suction them really good. We want to make sure that we're assessing them. Is their respiratory rate going up? Are they seeming to have more retractions? If they're going in a pattern that they seem to be having more respiratory distress, it would be a red flag for us that we need to give them more support. We'll give them oxygen. Oxygen helps, but really we want to get rid of those secretions. They might need IV fluids because, again, they want to breathe more than they want to eat. And if they're working that hard to breathe and they're tachypnic, they're losing more fluids just from, respiratory. So making sure that they stay well hydrated. And this can be prevented as well with Synagis. Synagis is kind of like getting a flu shot. It is not given to healthy individuals. It is ordered for premature babies. So we give it again in the winter and the springtime. Insurance will cover it, thank God, because it is buttload expensive. Has anyone had a baby? Yeah, it was expensive. Did you ever get to see the bill with how much it actually? It's like thousands of dollars. So it's expensive, and it's kind of like a flu shot in that you give it, and it doesn't guarantee you're not going to get RSV, but it greatly decreases the risk. And the only reason they give it to premature babies is because, again, because of their comorbidity of being premature, their lungs aren't as developed as well, and they're just at higher risk for developing it. And also, when they do get it, they just don't compensate as well. So we give it to them to help kind of prevent it. All right. Any questions about that? All right.